Today we're diving into something, well, quite heavy. It's a question that healthcare researcher Michael L. Millenson has grappled with for, what, 3 decades now?
That's right.
Given the really terrible toll of preventable medical harm, why have so many good people in healthcare, done so little to stop it? It's a tough one.
It really is. And Millenson, he gave a very blunt answer back in 2010, an answer that's still, frankly, unsettling today. After another decade and a half, maybe over 1 million more preventable deaths.
Wow. So what was his answer?
Three things: invisibility, inertia, and income. And that's what we're going to unpack in this deep dive. Because, understanding these is probably the first step.
Okay, let's start with invisibility. You often hear that comparison, right? Plane crashes are big news, public. Medical errors, they happen behind closed doors.
Exactly. But Millenson says it goes much deeper than just that.
Like how? He asks why major groups, say the American Heart Association, American Cancer Society, why aren't they leading the charge against medical errors?
Yeah, that's a great point he makes. And also think about patient stories. They're incredibly powerful, but often they focus on the general lessons learned.
Right, you don't always hear, this happened at this hospital on this date. Is that part of the invisibility?
It definitely contributes because, while that lack of specifics, it lets everyone, professionals, the public, kind of sidestep a really uncomfortable truth.
Which is?
That this can happen anywhere. Even if you're well-educated, even at a hospital with a top reputation, you're not necessarily safe. It keeps the problem feeling distant, abstract.
And language plays a role, too.
Oh, absolutely.
Yeah.
Millenson points out how language itself obscures things. Back in the 80s, there was this term iatrogenesis.
Which means?
Basically, harm caused by medical treatment. A powerful idea, but honestly, who understood that term outside of medicine? Almost no one.
Okay.
And now we've kind of swapped Greek for geek speak. We talk about HACs and HAIs.
Healthcare-acquired conditions, healthcare-associated infections.
Right. Yeah, those acronyms, they sound technical, maybe efficient, but they can also diffuse responsibility. They make it harder to pin down accountability for specific events. It hides the human element.
So the harm is often hidden, sometimes even by the words we use. And that leads straight into the second point, doesn't it? Inertia.
Exactly. The lack of action.
David Katz, he's a physician who actually lost someone to medical error. He described it so powerfully. He said it's like a system full of caring, expert people that somehow still gets stuck in routine and dangerous dysfunction. It's almost like the system itself just accepts a certain level of harm as inevitable.
Well, yeah. And for decades, that was often the attitude, maybe implicitly, and the data backs this feeling up.
What does it show?
There was a 2022 AHRQ survey, found that 52%, over half of hospital management, seem to only get interested in safety after something bad happens.
Reactive, not proactive.
Precisely. And another survey, this one by the American Hospital Association, found only half of hospital boards listed quality as one of their top priorities. Half.
That's not encouraging.
Not at all. And even when rules are made, like the Joint Commission's hand hygiene rule in 2021, Millenson argues they can be, toothless. No specific targets, no real teeth for enforcement across the board. It shows how deep the inertia runs.
Okay, so we have invisibility breeding inertia, which brings us to the third eye. Really difficult one. Income. Money.
Yeah, the touchiest topic, as Millenson calls it.
The whole idea that we constantly need a business case for patient safety. I mean, some people find that infuriating. Why do we have to justify saving lives with a spreadsheet in this area when we wouldn't for other life and death issues?
It's a profound question, isn't it? And it's not theoretical. There are actual studies looking at the quote-unquote business case for preventing, say, bloodstream infections from central lines, clabesises in pediatric ICUs.
In kids.
Yes.
Yeah.
Or for kids with blood cancer. Or even cost-benefit analyses for preventing patient falls. One study estimated a falls prevention program could cost just 88 cents per hospital bed per day.
88 cents?
88 cents. And yet, Millenson points out, safety initiatives like these get quietly axed due to an inadequate financial return. It's stark. Human lives versus sometimes literal sense.
So it paints a pretty grim picture. Invisibility, inertia, income. What can actually be done? Where's the hope?
Well, the first step, Millenson insists, is just honesty. Facing the problem head on. Acknowledging these dynamics exist.
Okay.
And there are positive signs. Things are happening to try and break down these barriers. Look at the Leapfrog group.
Right, they grade hospitals on safety.
Exactly. They make performance visible, hospital by hospital. That transparency creates pressure. It chips away at the inertia. And Medicare is taking a big step, too.
How so?
They're starting to tie hospital payments more directly to public reporting on patient safety culture across 5 different areas.
So linking money to safety performance, value-based care in action.
That's the idea. It pushes towards accountability, making safety part of the core financial equation, not just an optional extra when the business case works out.
So there is movement. The patient safety community is making a difference, saving lives. We have to remember that.
Absolutely. But, as Millenson says, it's just not enough and not rapidly enough.
Right.
So the takeaway, I think, is pretty clear. We have to actively work to make the invisible harm visible. We need to demand accountability to replace that inertia. And we have to stop accepting that phrase, money and mission, as a valid reason for good people to tolerate preventable suffering.
So for you listening, the question becomes, how do you engage with this? Whether you're a patient, a family member, working in the system.
Yeah, how do you help make things visible? How do you challenge the status quo, the inertia? And how do you advocate for a system where income doesn't silently override safety? That's the challenge Millenson leaves us with.